Thank you so much. I'm Michelle Kim, and it's my pleasure to welcome you to this evening's educational offerings, or I should say it's evening here in Cleveland, but we have many attendees from all across the world. We welcome you today to a very special program. And thank you really to over 600, close to 650 healthcare providers who have registered for today's event from over 80 countries. You come well represented from across the globe, and we're so thrilled to have you with us. We've got really a very special program for you. I'd like to thank our sponsors, as you can see here, Medtronic, Janssen Biotech, Cook Medical, and the Olympus Corporation. And I'd also like to introduce our terrific faculty, our course directors, Carol Burke, Carol Macaron, our Cleveland Clinic faculty, Amit Bhatt, Michael Cruz, Justina Cho, David Liska, Lady Catherine Major Perez, Sarah McGee, and Carol Rufael. And with that, I think I'm going to perhaps turn it over to our faculty. And if I could just be sure, I think it's going to be either Dr. Macron or Dr. Burke.
Thank you. Thank you, Dr. Kim, for the introduction. We are very excited to have you all join us for this live from Cleveland Clinic. In our program, we have planned 3 case presentations. Each will be followed by a brief talk on the providing updates on management. We would like this to be as interactive as possible, so a few suggestions. Throughout the case presentation, there will be questions, and we would encourage the audience to answer. You can type in your answer in the chat box. As well, we encourage you to type all your questions. We will be closely monitoring the chat box and tending to these questions as they arise. I would like to introduce our panelists. I'll start with Dr. Bhatt. He's a gastroenterologist and an advanced endoscopist with a specific interest in endoluminal surgery. Dr. Rufeich is a gastroenterologist who is interested in GI and gastric intestinal metaplasia and gastric cancer. Dr. Liska, colorectal surgeon and director of the Sanford Weiss Center for Inherited Colorectal Cancer. Dr. Chu, gastroenterologist who practiced in Korea and has a specific interest in gastric intestinal metaplasia and early gastric cancer. Dr. Cruz, GI pathologist with interest in GI neoplasia. Sarah McGee, genetic counselor, specialized in inherited GI cancers. And last but not least, Dr. Perez. She is our advanced fellow in hereditary cancer syndrome. So thank you all for being here. We will go ahead and get started with our first case. This is a 59-year-old female who presented to the office to discuss endoscopic sleeve gastrectomy. Her past medical history is significant for hypertension, hyperlipidemia, diabetes, NASH. Her BMI is 42. She reports a history of iron deficiency, anemia, needed IV iron infusions a few years back. B12 deficiency required injections for a while and now currently on oral supplementation. Her surgical history is significant for hysterectomy. She does not have any family history of cancer. However, her father was adopted and this side of the family history on that side is limited. She never smoked, no alcohol, and she recently relocated from Ukraine. This is her medication list. Other than aspirin, she's on metformin, blood pressure pills, B12 supplementation, and vitamin D. And as part of the sleeve workup, pre-sleeve workup, she underwent an upper endoscopy. The esophagus and duodenum were reported to be normal. In the stomach, and you can see the pictures on the right, the report described 5 small polyps in the gastric body, and 2 of the largest polyps were removed by biopsy. The path from those polyps came back atrophic gastric mucosa with intestinal metaplasia and no dysplasia. And this leads us to the first question: what would you do next? Would you proceed with the endoscopic sleeve gastrectomy? Would you decide to repeat the endoscopy to re-examine the stomach and see to what degree is there a change in the lining, or just forget about the sleeve and offer medical treatment for weight loss. And this is a question to the gastroenterologist on the panel. Obviously, when you read atrophy, intestinal metaplasia, those are changes that are thought to be on the pathway to gastric cancer. So maybe Dr. Bott, if you want to comment, what would be your next step, or is there any flags in the history or perhaps on endoscopy that would make you proceed one way or the other? Can you hear me?
You may be muted, Amit.
To me, Dr. Bach. I think I'm
Whoever wants to.
So anyways, the endoscopy showed a pale glistening mucosa of the body. That typically the atrophic gastritis we can guess. And then some nodular area is the polyp. It might be a polyp, it might be the intestinal metaplasia, I think. But it is limited data. So we have to repeat the EG, the whole gastric area.
And what did you think of the appearance of the stomach, like the flat looking lining? Is that something that would raise suspicion that there's atrophy throughout?
Yes, I think so. Typical atrophic gastritis showed a pale glistening, the sparkling mucosal surface, and then prominent submucosal vasculature. And then if the atrophic gastritis progresses gastric intestinal metaplasia, we can see some white nodular pattern, but I cannot see this patient in the body.
I see. So this is what we end up doing. We held off on the sleeve and we proceeded with the repeat upper endoscopy. And those are the pictures from the repeat exam. All of them from the body, proximal, mid, distal, and then this is the fundus. And you can also see the polyps that were reported before. And this is how the antrum looked. This is the pylorus, prepyloric mucosa. And there's an inflammatory appearing polyp there. So Dr. Chu, how would you describe the irregular lining?
We already saw the atrophic body. So relatively good is antrum, but in prepyloric area, we can see the white clay nodularity. This is a typical gastric intestinal metaplasia picture in white light endoscopy. So we can guess that this patient has the involvement of the body and antrum. But as I told you, it is typical reverse atrophic gastritis pattern. So H. pylori chronic atrophic gastritis, the atrophy start on the antrum, expanded body, but this case is reversed.
I see.
Carol, there's just a couple things in the chat. So Dr. Akapulu early on said endoscopic sleeve versus laparoscopic sleeve. So that might be a question we want to tackle at some point. And then Dr. Aladari suggested a repeat endoscopy. So I think some people may wonder from our experts, repeat upper endoscopy for what actually? What would you do with a repeat one?
I think those are some really good questions. I think when it comes to, endoscopic versus surgical, in a sleeve gastrectomy, surgically, you could remove that part of the stomach rather than that mucosa being hidden with an endoscopic approach. And then potentially you're getting rid of any gastric mucosa that might need surveillance at the time of surgery. Regarding the question of repeat endoscopy and should these patients get repeat endoscopies to look for extensive atrophic gastritis and intestinal metaplasia or surveillance moving forward, it would be great to hear from our expert, Carol Raphael. Carol, you're in?
Yes, I am, Dr. Bhatt. Thank you. I agree with you. With an endoscopic sleeve gastrectomy, we are suturing a part of the mucosa closed, which will hinder any potential need for surveillance down the line. This is a patient who has atrophy and intestinal metaplasia in the body of the stomach. At least this is the limited data we had from the first endoscopy. The fact that there is intestinal metaplasia in the body suggests that this patient could be at an increased risk, and further data is needed in terms of topographic extent of metaplasia, because if it's extensive, involving the antrum and the body together, then this is a high-risk patient. And the last thing we want to do is a gastric procedure that would refrain us from accessing parts of the stomach for surveillance down the line if the patient is deemed high risk.
Right. So here we go. This is the path from the repeat exam. There was biopsies were taken according to Sydney protocol. As noted here, the biopsies taken from the antrum showed intestinal metaplasia as guessed by the appearance. There was also intestinal metaplasia seen on the incisura biopsies, and the random and targeted polyp biopsies from the body showed chronic atrophic gastritis, enterochromaffin cell hyperplasia, intestinal metaplasia. There was no dysplasia. I think we have Dr. Cruz with us, and it would be nice to hear from the perspective from a pathologist standpoint. How easy is it to recognize atrophy? Is this underdiagnosed? Can we stage to what extent is the atrophy as well as the intestinal metaplasia?
Yeah, so one of the things with these is I always think that is an underdiagnosis. I think one of the challenging things here, and that's always helpful from a pathologist perspective, is to review the endoscopic findings as well as this, because oftentimes when we're looking at this, it really starts to look like inflamed antrum mucosa, right? You have the loss of the parietal cells and the chief cells, and so it begins to take on a antral type appearance. So knowing, where you're taking the biopsy from, what it does, helps us to inform our opinion on that. And we do see intestinal metaplasia. Oftentimes in these cases, it's going to be the incomplete type of metaplasia. We also commonly will see other types of metaplasia, such as we see the pseudopyloric, as well as we see pancreatic type metaplasia. And so, and along with these, we'll talk further probably in other cases about, these being risk for lesions that are epithelial dysplastic lesions, as well as those associated with neuroendocrine lesions.
I see. And when we test for H. pylori, is it typically done on both body and antrum specimen or only on the body?
We'll typically do on both, right? Because I think one of the things is, whether, you can still have Helicobacter gastritis as an associated cause, but, this can also be the autoimmune metaplastic atrophic gastritis. And just because you have autoimmune metaplastic atrophic gastritis doesn't mean you can't also have Helicobacter disease.
Yeah. So at this point, after reviewing the pathology, what would be your diagnosis? Are we dealing with autoimmune atrophic gastritis? Is this an multifocal gastritis in the setting of H. pylori, or any other diagnosis you may have? And my question is to you, Dr. Raphael. I know that atrophic gastritis in the setting of an autoimmune condition is typically limited to the stomach. So how often do we see this multifocal disease, and would a negative H. pylori on biopsy be enough to say this is not H. pylori driven? To what degree do we say we've done our due diligence and ruled out any other environmental cause?
I think based on the data we have so far, autoimmune atrophic gastritis is definitely high on the differential because of the histopathological changes, including a severely atrophic body or absence of oxyntic mucosa and enterochromaffin-like cell hyperplasia and early neuroendocrine tumors, if I recall from the pathology report. The only thing to keep in mind, and then plus she also has iron deficiency anemia and vitamin B12 deficiency, which could be in the setting of pernicious anemia secondary to advanced autoimmune gastritis. The only thing to keep in mind is that in theory, autoimmune gastritis is a disease that predominantly affects the corpus and oxyntic mucosa, or is more so restricted to the oxyntic mucosa, and this patient has antral involvement. Could this still be autoimmune gastritis? Yes, but in theory, this is only autoimmune gastritis is restricted to the corpus. So while autoimmune gastritis is high on the differential, it's still important we rule out H. pylori as a concurrent or previous infection responsible for those antral changes.
Yeah, and this is what we end up doing. The autoantibodies came back positive. The parietal cell antibody were positive. Gastrin level is high, and patient is not on PPI, so that goes along with hypochlorhydria. The H. pylori stool antigen was ordered as an attempt to add more certainty that we don't have an active H. pylori infection, but that was unfortunately not yet completed by the patient. I think this concludes our case, and I will turn it over to Dr. Rafael to go over some of the updates on management of gastric intestinal metaplasia and atrophy.
Thank you, Dr. Macaron. I'm going to go ahead and share my screen. Is everyone able to see my slides?
Yes.
Great. So for the next few minutes, I will be talking to you about the management of gastric intestinal metaplasia, or GIM, particularly surveillance. Why does GIM matter? It matters because it's a preneoplastic lesion. So this is the chorea cascade, which, as you know, is the widely accepted model in the pathogenesis of intestinal type gastric cancer. You see intestinal metaplasia here is a preneoplastic step when it arises in a background of atrophic mucosa. And with that being said, just like Barrett's esophagus, just like colorectal adenoma, adenomatous polyps, this is an opportunity for us to implement screening, surveillance, early detection, and prevention of cancers whenever we have a preneoplastic lesion identified. And that is the goal when it comes to GIM surveillance. Another reason it matters is because it is relatively prevalent in the United States, with a pooled prevalence estimated at around 5% and up to 20% in some ethnic subgroups. The risk of progression to gastric cancer, however, is low, with a cumulative risk of 0.4% at 3 years and 1.6% at 10 years, which means that it is important to identify high-risk individuals and offer surveillance to this group of patients rather than all comers, as the majority of those will be low risk. Whenever I see a patient with GIM and I think about management, there are 3 essential buckets in their management that I think of. The first one is risk stratifying the patient. The second one is ensuring the patient gets a high quality endoscopic examination. And then last, making sure I offer surveillance to high risk patients, or in other words, when indicated. So we can start by reviewing the risk factors for GIM progression to gastric cancer that have been established in the literature. The first one is a family history of gastric cancer. So patients with a first-degree relative with gastric cancer have been shown to be at a 4-fold increased risk of progressing to gastric cancer compared to those with no family history. H. pylori infection. So do they have a persistent or an active H. pylori infection? And if that's the case, we want to make sure we treat them and confirm eradication of the infection, because the risk of progression will decrease. It will not nullify for sure, but the progression can become slower and the risk will decrease. Extent of gastric intestinal metaplasia, just like the case we saw at the beginning of this session. Is it limited or is it extensive? And by limited, we mean limited to the antrum with or without an incisura involvement, And by extensive, we mean extending into the body and or fundus of the stomach. And that's important because extensive GIM has been shown to be associated with increased risk of progression to gastric cancer compared to those with limited GIM. And this is where the Sydney protocol comes into play. So whenever we're taking random biopsies to map, they should not be random per se, because you want to try and target areas of concern or suspicion for metaplasia. But whenever we're taking random biopsies, you want to take 2 biopsies from the antrum, the greater and lesser curvature, and 1 from the incisura, group them in 1 container and separate them from the biopsies we're going to take from the lesser and greater curvatures of the mid-body, as Dr. Cruz said earlier, so we can help our pathologists tell us better where we're at and what the extent of atrophy and metaplasia is. And then we have 2 histological characteristics. The first one is the histological severity, which is not done in the United States, but done outside the US, and it's based on the Olgem stage, or the operative link on gastric intestinal metaplasia assessment. What does this consist of? It's a staging system that takes into consideration the severity of GIM under the microscope, but if you look at this as this table here, there is no way we could provide a stage unless we have the topographical extent as well. So we need biopsies from both the antrum and the corpus to provide a stage of for the severity for this patient. And the studies have consistently shown that stages 3 and 4 are more so correlated with progression to gastric cancer compared to stages 1 and 2. Another histological characteristic or risk factor is the histopathological subtype. Is the intestinalization of the gastric epithelium complete, meaning looking more like a small bowel with a characteristic appearing brush border, as you see here? Or is it incomplete, meaning looking more like colon without a brush border and with intervening columnar mucin-secreting cells? This matters because, again, studies have also shown that the incomplete subtype is more so associated with progression compared to the complete subtype. Those 2 histological characteristics are not routinely performed in the United States, and this is where we need to work hand in hand with our pathology colleagues to identify barriers to implementing those histological characteristics, as well as hopefully come up with standardized pathology protocols down the line. Other risk factors that are known to be associated with gastric cancer per se, rather than just risk factors for GIM progressing to gastric cancer, are factors like race and ethnicity. So as we all know, there are high incidence regions in the world for gastric cancer and other low incidence countries and regions. And it's whenever we're practicing in the United States, it is important we take into consideration whether the patients we're seeing are 1st or 2nd generation immigrants from those high incidence countries, and kind of be more cautious when managing and working with those patients because they are at increased risk. Age, so older age is associated with increased risk of gastric cancer. And then finally, the patient in clinic is going to ask us, what is it they could do to decrease the risk of progression or prevent cancer altogether? There are no treatment options available out there, as we know, but there are some lifestyle habits that we could counsel against, such as smoking, high salt diet, processed foods, all of which have been associated with gastric cancer. Next is high quality endoscopy. So this is a very essential and crucial point here, and a very important part of the management in the management of those patients. Why does it matter? Because gastric neoplastic lesions can be very subtle, and a meta-analysis from 2016 showed that the miss rate can be as high as 10% for gastric cancers. So what does a high-quality endoscopic examination entail? 1, ensuring excellent visualization of the mucosa by cleansing well, using mucolytic and defoaming agents when needed and when available, and then insufflating and distending the stomach appropriately to avoid missing any lesions. Second is following a systematic approach. So maybe starting with the antrum and going proximally by looking at all gastric parts, all walls and curvatures in different parts of the stomach, for providing good photo documentation and complete photo documentation of those gastric parts, as well as any lesions of concern. And it goes without saying that high definition white light endoscopy with image enhanced technologies and chroma endoscopies should be used when available. And targeted biopsies should be performed whenever we have lesions of concern, and those would be dysplastic lesions or early neoplastic lesions that we are to be concerned about, with a detailed description of their shape, their size, their location, and documentation. Gastric mapping, according to the Sydney protocol, as we just saw, and then spending enough time examining the stomach. So there are no quality metrics set for endoscopic upper endoscopy like we have for colonoscopy, but a minimum of 6 to 7 minutes has been proposed when it comes to surveying the stomach. Is it easy to identify GIM? We just saw a typical GIM lesion in the antrum when we looked at when we reviewed our case together, but there are patterns that have been described and that we should be aware of, such as the tubulovillus pattern you see over here. This is a picture under near focus. The light blue crest sign that you can see here, and those are representative of the microvilli. And then the white opaque substance, which is fat droplets that can accumulate in those villi. The specificity for those patterns is very high, but their sensitivity is not and varies widely, as you can see here, even when using image enhanced technologies or magnifying endoscopy. And last is surveillance. Who should we offer surveillance to? There are different guidelines out there. We have the American guidelines, the AGA guidelines that were published in late 2019, the ESGE MAPS 2 guidelines or the European guidelines, the British guidelines, the Japanese guidelines, the Latin guidelines. And for the sake of this talk, I'm going to go over the European and the American ones. The AGA surveillance recommendations are more so of general guidance, if I can put it this way. And this is a nice clinical decision algorithm presented by the AGA. And the statement that we should pay attention to is that the AGA suggests against routine surveillance. And this statement should not be confused with a suggestion against surveillance, because the word routine is important. In other words, not all comers should be surveyed. So once GIM is identified or diagnosed, which most of the time is an incidental finding in the US, we want to test and treat for H. pylori, and then, of course, confirm eradication, and then risk stratify those patients based on the established risk factors I showed you earlier. If they have any of those risk factors, then we want to discuss pros and cons of repeating a surveillance endoscopy. And then if they agree, it can be offered every 3 to 5 years. If they don't have any of those risk factors and we're not satisfied with the quality of the index examination, then that's when we want to discuss pros and cons of repeating a short interval endoscopy to assess extent better and evaluate the gastric mucosa for any concerning lesions. And if they agree, proceed. We just saw a case on autoimmune gastritis. The AGA guidelines on GIM do not make any statements on autoimmune gastritis, but they do in an expert review where they recommend surveillance endoscopy every 3 years to be considered in those with advanced atrophic gastritis, like our patient with autoimmune gastritis. And then, of course, keep in mind that with autoimmune gastritis, we're not only surveying for early neoplastic lesions for adenocarcinoma, but also neuroendocrine tumors. And in those with autoimmune gastritis who are found to have neuroendocrine tumors, then they should undergo surveillance every 1 to 2 years. The European guidelines are more detailed and more streamlined, as you see in this algorithm over here. So again, after a high definition chroma endoscopy with either targeted biopsies or random biopsies according to the Sydney protocol, and after testing and treating for H. pylori, you want to decide what to do. And the decision process starts with determining extent. If we have atrophy without IM that is limited, meaning limited to the antrum, no surveillance is recommended. If we have IM limited to the antrum without any of the risk factors we discussed, and here they include autoimmune gastritis as a risk factor, which is not included in the American guidelines, then again, surveillance is not recommended. But if any of those risk factors are met, surveillance should occur every 3 years. If the atrophy or the metaplasia is extensive, meaning involving both the antrum and corpus, and the patients do not have any family history, regardless of other risk factors, they should undergo surveillance every 3 years. Unless they have a first-degree relative with cancer, then they should undergo surveillance every 1 to 2 years. This side here is for dysplasia, which is beyond the scope of this talk, but it's there. So some key takeaways: GIM is a pre-neoplastic lesion. And this is, again, very important because it's our opportunity to survey patients and detect neoplastic lesions early on, which is the goal of surveillance. When identified, we should test and treat for H. pylori and risk stratify patients. We want to consider repeat upper endoscopy for mapping and close examinations whenever we have concerns about the quality of the index exam. As gastroenterologists, we should be comfortable identifying GIM endoscopically, which again falls under performing a high-quality endoscopy. And finally, offering surveillance to high-risk patients after a risk-benefit discussion. Thank you.
Thank you so much, Dr. Rufail. Just before we move on to the second case, there was a question in the chat. If the first biopsy showed GIM at the antrum in an old woman, 78-year-old female, should we bring her back to take biopsies, like to do the mapping?
That's a great question. So again, if we have concerns about the quality of the index examination, that is something to consider for sure. There is a GIM in the antrum. If we don't know what the status of the body is, or the procedure might have been done rapidly for a reason or another, then yes, it is definitely something we want to discuss with the patient. And if they agree, bring them back for further risk stratification. And also depending on other risk factors they might have or not. So it's really a conversation you want to have with the patient, but this is definitely something you want to consider. And whenever GIM is found, we should really make an effort to discuss the finding with the patient and go from there.
I want to add something about the case. I think the GIM has a hidden pre-malignancy on neoplastic lesion. So the very early gastric cancer or adenoma. So we have to be cautious about detection of the early neoplastic lesion. And this case is we have to find the subepithelial lesion because this case is autoimmune gastritis. So this patient can have the urocrine tumor. So I think I want to emphasize 2 things.
Thank you. For the sake of time, we're going to go ahead and move to our second case. I will turn it over to Dr. Perez to present the case.
Well, good afternoon, everybody. Let me try and share the slides here.
While we're waiting, if anyone can look into the chat and answer some of the questions about chemo prevention, can the patient go on to sleeve, laparoscopic sleeve? If so, any of the experts or the panelists, can you please weigh in on the chat?
There's a question here about the need to separate antral and body biopsies. Carol, do you want to address that question? Carol Rufail?
Sure, happy to. So it's important to separate. It might not be important in a normal stomach because the pathologist will be able to clearly tell whenever we are dealing with axanthic mucosa, meaning from the body, versus antral mucosa. But whenever there's atrophy and both specimens are mixed together in one container, when the axanthic mucosa is atrophied, it looks more like antrum. So it will be hard for the pathologist to tell whether all those specimens are originating from the antrum or whether we're dealing with atrophied axanthic mucosa that underwent pseudopyloric metaplasia and has been antralized, looking like an antrum. Dr. Cruz is on. If you'd like to add anything to what I said, please do so.
Nope, that is perfect, especially sometimes if we're questioning whether this is from the transition area between the axanthic and antral mucosa. It provides an opportunity that we may not evaluate it thoroughly, so knowing where it comes from helps us in our differentials and evaluations.
Dr. Perez, go ahead, please, with your case.
Well, thank you so much. So can people see my slides?
Yes.
Perfect. So we're going to go ahead with case number 2. So this is a 32-year-old woman who's seen in colorectal surgery clinic for second opinion after being diagnosed with rectal cancer in March of this year. She has a past medical history of stage 3 non-Hodgkin lymphoma when she was 20 years old. She underwent radiation and chemotherapy. The radiation was to her neck, chest, and upper abdomen. Did not have any surgeries before, doesn't have any history in her family of colorectal cancer. Her father had leukemia. Her grandmother had lung cancer, but she was a smoker. And her great-grandfather had pancreatic cancer. She didn't have any history of cigarette or alcohol, drugs. She did vape, and she also had a child who was born in 2021. So she presented initially because she was having intermittent hematochezia that started out about a year and a half before her diagnosis. She had abdominal pain, nausea, vomiting, and lost about 15 pounds in the previous 2 months prior to presentation. She went to the emergency room back in January, and she had a CT abdomen pelvis that basically showed thickening of the rectus sigmoid that raised some concerns about recurrent lymphoma. So she had 2 months later a colonoscopy, and this is what the outside hospital colonoscopy report showed. So basically, there were 5 different polyps in the transverse colon that were found to be SSP. She had 1 tubular adenoma in the descending colon. She had multiple sigmoid colon polyps. The report doesn't really specify how many there were, but they were different histologies, including tubular adenoma, tubulovilous adenoma, and also hyperplastic polyps. She also had high-grade dysplasia in the tubulovilous adenoma. And then more concerningly, she had a rectus sigmoid mass of 25 centimeters that was found to be invasive moderately differentiated adenocarcinoma arising from a background of tubulovilous adenoma. The immunohistochemistry showed intact nuclear expression of MLH1, PMS2, MSH2, and MSH6. So at this point, what do you suspect? So those who are listening to us, you're welcome to chime in and provide us with your differential diagnosis. And here are some options for you. So inherited polyposis syndrome, therapy-associated polyposis and cancer, or sporadic. So you can drop your answers in the chat.
So would like to hear from Dr. Liska. So this is a young woman survivor of an early adult cancer who comes into the clinic with over a year history of bleeding, took over a year to get a colonoscopy, diagnosed the rectal cancer, but also at least 8 other precancerous polyps. So what do you think is going on? What would you want to do next?
Yeah, I mean, obviously the primary concern is the cancer that she has, that was found, and she will need staging for that. But in terms of the overall picture of what's going on, the types of polyps she has, we don't have a clear answer, but with her history, therapy-associated polyposis is definitely on top of the differential. It really sounds like very typical for one of these cases from the original report out of Boston when they reported for therapy-associated polyposis initially. But definitely serrated polyposis syndrome would be another consideration. CPUE would be a consideration, but I think I would like to repeat a colonoscopy, especially with the sigmoid polyps, where we didn't get an exact number, and there was something. One of the polyps had high-grade dysplasia, so we want to make sure that we know that all the polyps have been removed, but the primary concern is the rectal cancer that was found. And with her history of symptoms, right, she's had bleeding for a long time. You are worried that this is advanced disease, so staging is going to be important.
Okay. Dr. Burke?
Yeah, I just want to make a couple important points. So it would be important to know sizes. And when you see a patient with numerous polyps, rather than putting everything in one jar, that you actually put polyps in different jars by location in the colon, because at least in the United States, outside of someone that has cancer at a young age, for polyposis, there are certain guidelines and insurance coverage if you have a certain number of cumulative lifetime polyps. So if you just lump everything together and you have HPs and you have sessile serrated polyps, you have tubular adenomas, you don't know how many of each. So I would suggest for at least the baseline exam when you're trying to get an assessment of what's going on is to be very particular about number, size, location, and then the bottles and pathology.
Yes.
All right, thank you very much. Now, based on the differential diagnosis that we've got so far, then what would be the next step? And here are some of the answers and options. So do we repeat a colonoscopy and also add on an EGD at the same time? As Dr. Liska suggested, stage with more imaging with CT, abdomen, chest, pelvis, and also obtain MRI of the pelvis, refer for genetic testing, or all of the above.
You can keep going. I think that the next step shows the test that we're done.
There we go. So as our panel suggested, we did a repeat colonoscopy. She had 6 small hyperplastic polyps in the rectum and then a malignant partially obstructed tumor at 20 centimeters that was proximal to the anus. The upper endoscopy was absolutely normal, did not have any gastric or duodenal polyps. And then now she went on to having genetic testing, and at this point, she had different cancer panels that were done, and I would like to have the input of Sarah McGee to see exactly what we'll be testing in a patient like with this case with prior history of non-Hodgkin lymphoma, and who's presenting with multiple different polyps and also cancer. What exactly we'll be looking at when we're doing genetic testing?
Yeah, so given her young onset colorectal cancer, we do recommend, testing for genes associated with colorectal cancer for anyone under the age of 50. Here, typically, in the United States, most institutions are doing pan-cancer panels, so we're not focusing only on the cancer that the patient presents with. So our custom cancer panel has 55 genes at baseline covering, breast, ovarian, colon, uterine, prostate, pancreatic, and some, other rare tumor types. We added on some additional given the history of polyps to cover some, rare polyposis syndromes, emerging evidence genes related to colon cancer, and then added on genes related to leukemia given the father's history of leukemia. As far as non-Hodgkin's lymphoma goes, typically the vast majority of the time we're not finding a genetic cause to that. So the biggest concern was, her young colorectal cancer diagnosis and the polyps that she's had, keeping in mind that it could all be treatment related, but, definitely still want to double check that there might be an inherited cause to it.
Mm-hmm. Thank you so much. So in this case, this patient was tested for the ones you've just mentioned, so that included basically MVD4, and then the ones for colorectal cancer, and all of these were negative for this patient. So she was not found to have any germline pathogenic variants. She went on to have her staging imaging that basically confirmed the 4 centimeter lower sigmoid colonic mass. She also had some suspicious lymph nodes in the mesentery, but it was really unclear what to make out of this because she had lymphoma in the past. And then the MRI pelvis showed 5.8 upper rectal tumor that straddled the anterior peritoneal reflection. And there was also extramural vascular invasion with extension into the mesorectal fat. She also had some mesorectal and superior rectal lymphadenopathy. So it was staged as stage T3B with possible positive lymph nodes. So as far as the mesorectal fat, it seems like it was clear because there was tumor margin more than 2 millimeters from the mesorectal fat. And then there was no sphincters involvement, and there were no any other suspicious extra mesorectal lymph nodes. So this concludes our case. So if we could hear also from Dr. Liska as what to do with this. And then other thing to do is, based on this information and the staging that we have so far and where it's located, I wonder if there are any thoughts on what should we do for next steps.
Dr. Liska, we'll turn it over to you for your talk. I think you're on mute.
Sorry, it's been a few years with this online Zooms and I still haven't figured it out. So, the location of the tumor is critically important for rectal cancers. Whenever we're talking or suspecting rectal cancer, the actual location of where the tumor is very important in terms of the next steps in treatment, be it neoadjuvant therapy or direct going to surgery. And it's interesting, if you look at the slides that you've presented, the first colonoscopy said that the tumor was at 25 centimeters, then the next one said it was at 20 centimeters, then the CAT scan says it's I think a lower sigmoid, and then finally the MRI said it's a upper rectal cancer. And you know, especially when you're dealing with these tumors that are in the rectal sigmoid area, it is sometimes unclear where exactly they are. A rigid, I'm seeing in the chat, somebody's mentioning a rigid proctoscopy or rigid sigmoidoscopy is a very good way of determining it. But nowadays, really, the way we decide of what we consider a rectal cancer as opposed to a colon cancer in terms of the need for neoadjuvant therapy is the relationship of the tumor to the anterior peritoneal reflection, which is a landmark that can be seen on MRI the best. And you know, there's some correlation between that and the rectal valves of Houston. However, the MRI is the most accurate way of assessing that. And as the MRI showed in this case, it was straddling the peritoneal reflection, the anterior peritoneal reflection. When a tumor is, any part of it is below the anterior reflection or at the anterior peritoneal reflection, we considered it a rectal cancer. And with this being a T3 tumor, you know, again, the mesorectal lymph nodes were a little bit equivocal because of a history of lymphoma, but because it's a T3 tumor, it is considered a locally advanced rectal cancer. And generally speaking, these are the patients that then would be treated with neoadjuvant therapy. And, you know, that's a whole topic in itself. But generally speaking, in most cases, in our institution would start with neoadjuvant chemo and radiation. Her history makes it a little bit more complicated because she has a history of lymphoma and she has a history of radiation before. Our radiation oncologist would want to get a very sort of precise history of what the radiation included last time when she had the radiation. You know, was the pelvis included? Was the rectum included? What was the dosages to see if she would qualify for radiation again? So you know, I don't want to distract from the topic of therapy-induced polyposis here, but it gets quite complicated in this setting.
Thank you so much. Do you have any slides you would like to share?
About the case or
about management? I'm just
Yeah.
double checking before we move on to the third case.
No, right. I have a talk about
Go ahead.
yeah. Well, I'll share my screen. Yeah.
Yes. And Dr. Burke, in the meantime, is there any guidance on when we should screen patients who were exposed to abdominal radiation or chemotherapy with alkylating agent? Was this patient, is there any guidance to gastroenterologists?
Thank you for asking. That's a really important question, and there are guidance on adult survivors of childhood cancer. There's a big European cohort, and there is also a cohort in the United States. And basically, they have an increased risk that seems to begin earlier in life and potentially more advanced lesions, but it's beginning at the age of 35. And most of these non-GI or non-surgical organizations suggest that you can choose average risk options. And so, you know, what I would say as a gastroenterologist, if you have an increased risk, then a colonoscopy is the way to go, because about 6% of individuals with non-Hodgkin's lymphoma that have polyposis, actually, this is European data from Decker's group, showed that 6% of them met the criteria for serrated polyposis syndrome, which may not be picked up either on FIT, and Cologuard does pick up big serrated polyps. So I would say that in these individuals, you start early every 5 years pending the findings. And I think colonoscopy is probably a much better strategy than FIT. I don't believe that they're average risk.
Okay, thank you. Dr. Liska, the stage is yours.
Great, thank you. So I'll go quick through the beginning here. So this is, all slides we've become very familiar with, how, while the overall incidence of colorectal cancer is decreasing in the population in the United States, there is an alarming rise in young onset colorectal cancer, to the point that by 2030, colorectal cancer will be the leading cause of cancer deaths in individuals under the age of 50. And fitting with the audience we have here this evening, this is not a phenomenon that's just in the United States, but it is a global phenomenon, mostly in westernized countries. But this rapid rise in young onset colorectal cancer is happening throughout the world. The questions that come up, there are many important questions that come up about young onset colorectal cancer. The natural one that comes up most often is, why is this alarming rise in young onset colorectal cancer happening, and how do we stop it? And this is clearly a very active area of research. However, from a clinical standpoint, when thinking about an individual patient with young onset colorectal cancer, the two main questions are, number one, is it the same disease as in average age onset patients? And as a corollary then, should these patients be treated any differently than average onset people? And if so, how? And we know that there are many things in common between young onset and average age onset colorectal cancer, but there are also several important differences. For example, we know that young people are more likely to have a positive family history or microsatellite unstable tumors. They are more likely to have a genetic syndrome. They more commonly present with metastatic or late disease, and they're more likely to have rectal cancers, like the case we just discussed, with most of the tumors in young people being on the left side of the colon. Older people, on the other hand, often have earlier stage tumors because they undergo screening, and they're more likely to have tumors on the right side of the colon. So I will be talking about some of these essential differences between young onset and older onset people, and how that would potentially affect treatment. And as a colorectal surgeon who takes care of a large number of patients with hereditary colorectal cancer syndromes, I want to emphasize that one of the clinical considerations that are particularly important in young onset people is the need for germline genetic testing. And studies have shown that in young patients with colorectal cancer, there's a significantly higher incidence of hereditary syndromes. And missing a diagnosis of hereditary syndrome can have important implications, not only for the patient, but also the families, from a treatment standpoint and also from a surveillance standpoint. So given these significant implications, the NCCN has recommended germline multigene panel testing in all young onset colorectal cancer patients, just as Sarah just said. And although many centers, including ours, we have been doing this for many years now already. So Harim Said, she's one of our internal medicine residents. She recently examined how well we were doing in terms of assuring that genetic testing is happening for all our young onset patients. And we hypothesized that, notwithstanding our good intentions, the actual rate of referral to genetic counselors is still too low, despite a relatively high incidence of pathogenic variants in these populations. And to study this, we examined the frequency of referral to genetic counselors among our patients over the last decade, and we excluded patients with IBD or those with a known hereditary cancer syndrome. So this is what we found. We found that only 60% approximately were referred to genetic counselors. And of those, about 80% completed their appointment, and then 97 got genetic testing. But really what was important is that almost 40% were never referred for genetic testing. We looked at some of the factors, and a multivariate analysis, as one could expect, young age at diagnosis, so the younger the patient was, a positive family history, were both associated with referral to genetic counselor. And we also saw that we've sort of improved over time, and if they were diagnosed more recently, they had a higher likelihood of being referred for genetic counseling. And this looks at it again over time, where at the beginning, back in 2010, only about 40% got referred to genetic counseling, and more recently we're up to 76%, but definitely still not good enough. When looking at what the outcomes of genetic testing were, we found, similar to other studies, that the incidence of pathogenic variants was relatively high at 21%, with the most common being hereditary syndromes such as Lynch FAP, and mute-YH associated polyposis. So to summarize the study, we found that while referral increased over time, even in the most recent years, about 25% of patients are not being referred to genetic counseling, and that younger age and a family history were associated with referral. And that the incidence of germline pathogenic variants is pretty high, with 1 in 5, and Lynch syndrome and FAP being the most common. And it really highlights the need to implement care pathways. Again, this is at a big institution where we have a lot of resources and we have genetic counselors such as Sarah, but you need to put care pathways in place that really optimize that the referral happens in all patients with young onset colorectal cancer. And that's one of these clinical considerations that is critically important in when you see a new patient with colorectal cancer who's under the age of 50. And some of the other clinical considerations that are important in young onset people, as we discussed, young onset tumors are typically occur in the distal colon and rectum at a 30% higher frequency than average onset colorectal cancer. And now, as we just discussed, patients with locally advanced rectal cancer, they usually require a multimodal and multidisciplinary approach. And these treatments, especially radiation to the pelvis, can have significant impact on bowel functions, sexual health, and fertility, body image, and again, factors that are particularly important in the young population. So fertility preservation is a big consideration in these young people. The majority of patients that undergo radiation to the pelvis will develop ovarian failure, and that's why guidelines recommend discussion of fertility preservation with all patients of reproductive age. Unfortunately, as you can see from this Canadian study, there's poor adherence to this guideline. Now, what's interesting, what they found is that even without actual implementation of fertility preservation methods, just having a discussion with the patient about fertility preservation, even if they don't end up going ahead and doing it, has shown to reduce long-term regret among survivors. So it's really critical that you need routine and universal oncofertility consultations for all young onset patients of childbearing age, both for female and male patients. I started mentioning some of the sexual and psychosocial health issues, and this is results from the Colon Cancer Alliance patient survey regarding fertility, sexual, and psychosocial health. And only 31% of patients were being referred to reproductive specialists, even though 37% of women and 16% of men developed infertility. And then 50% of providers failed to share the risk for sexual dysfunction. So not only were they not referred for consultation, they weren't even discussed the risk with them. 65% of patients developed dysfunction, and patients with ostomies reported a poor quality of life, particularly regarding sexual health and intimacy, and 75% of patients were employed full-time at the time of diagnosis, and 28% are now no longer working. So again, a lot of psychosocial issues in these patients that are really, when you look at these surveys that were filled out by patients, again, there's some selection bias there, but it's really stark when you think about it. This is a study that was presented as an abstract at the American Surgical Association, and you can see that while cancer diagnosis at any age is tough, the young people have a higher rate of emotional distress, fear, struggle with changes in their appearance, difficulty with managing work, and financial toxicity is a big problem in these patients. So it really stresses the importance of social worker and psychologists to help when taking care of patients with young onset colorectal cancer. Another feature that's particular to young onset patients is that there's a 40% higher risk for advanced stage of disease. Now, again, when you have an advanced cancer at any age, it's tough. However, what you need to keep in mind is that these young people, they're generally healthy, don't have many comorbidities, and have a good performance status. So these patients are usually good candidates for very aggressive chemotherapeutic and surgical treatments. And it's critical to have multidisciplinary decision-making to select the correct patients for curative intent surgery. And you need to coordinate surgical care because, again, with many different teams involved, the patient can sometimes get overwhelmed by this. However, one needs to keep in mind a caveat shown by some of these studies that more aggressive treatment does not necessarily result in better outcomes. And this is a large NCDB study where it was shown that young patients were more commonly treated with multi-agent treatment, even for stage 1 and 2 disease, where they were probably overtreated. So it's important to keep in mind that we shouldn't choose treatments based only on the fact that these patients can tolerate these treatments. It really should also be effective. So, with all these different specific treatment considerations to keep in mind, and others that I haven't gone into, we established a center here at our institution, the Cleveland Clinic Center for Young Onset Colorectal Cancer, with the goal of optimizing outcomes for young patients through a comprehensive and coordinated multidisciplinary care, research, education, and outreach. And the multidisciplinary clinical care involves a big team for clinical coordinators, genetic counseling, surgical approaches, etc. Our research involves a prospective registry, a biorepository, and a survey to look at environmental exposure so we can figure out why this is happening. And then education, outreach, and having patient advisors is critical as well. So this is our team, again, a large group of people, and we're very lucky to have such a large team of experts who are committed to our mission. And like I said, it can be overwhelming to patients. We provide them with a handout that helps them, understand what these different team members are really what their role is. The program coordinators help really the patients maneuver through this, but we have surgeons, genetic counselors, liver surgeons, gastroenterologists, fertility specialists, psychologists, social workers, palliative medicine, and wellness people to all help with the patients to help focus on all these different factors. So just for the take-home points, we know that patients with young onset colorectal cancer have specific diagnostic and treatment considerations that require specialized multidisciplinary care, including genetic counseling, fertility preservation, multidisciplinary treatment of metastatic disease, psychosocial support, surveillance and survivorship, and also wellness and preventions.
Thank you very much, Dr. Liska, for this informative talk. We are a little bit short on time. We will go ahead and move to our third case. Dr. Burke, if you want to take it.
Sure. Steve, could you bring up my slides? Thank you. It's a 48-year-old female who came into to my endoscopy suite for open access colonoscopy. She had a positive FIT DNA test, and on the examination, you could see a potpourri of the polyps that I saw. 8 polyps were resected, a 15 millimeter in the rectum, 3 2 to 4 millimeters in the transverse colon, 2 7 and 35 millimeters in the descending colon. 1, the largest, was removed piecemeal. 2 and 5 millimeters in the sigmoid colon, and on pathology, 6 of these lesions were tubular adenomas, and the largest 2 were tubulovillous adenomas with high-grade dysplasia. Quite a shock for a 48-year-old female. Next slide, please. So just, when you're faced with this in an endoscopy suite, you need to think about efficiency in the endoscopy suite. But what always raises my suspicion is, like, why the heck would this woman have these polyps at the age of 48, and especially in a woman? And so in the essence of time, I think we'll just move forward. If you could go to the next slide, please. So things that you need to think about is there some ethnicity or race that might be associated with it? And she's white. Her past medical history, is there something suspicious as she had other cancers, bilateral cancers, multiple tumors, whether they're benign or malignant? And is she a couch potato? Is she overweight and physical inactivity? Her BMI is 23. She exercises 2 to 3 days per week. She said her diet is typical American. Although she eats fruits and vegetables, she does admit to drinking diet soda and eating potato chips. Never smoker and no alcohol. So those are kind of some of the environmental things that I was thinking about. When you take a look at her family history, the heritage is Northern European, German and Irish, and German. And you can see the proband is where the arrow is. So she has this, all of these polyps. She had a maternal half uncle who had a rhabdomyosarcoma. Her father had an early onset glioblastoma, and she had 2 boys, ages 16 and 19. And the 16-year-old had sudden cardiac death. The other one has a Chiari malformation. So important to kind of start figuring out, is this a hereditary gastrointestinal polyposis syndrome? If you look on the maternal side of the family, you can see that there was an older age of onset colon cancer over the age of 50. Next slide, please. So because I removed one of the largest lesions piecemeal, I repeated the exam within 6 months. 6 additional polyps were seen. Not necessarily that I dismissed them at the time, but my focus was on the large lesions. She had 2 at 1 to 2 millimeters in the cecum, 1 2 millimeter in the transverse, 2 at 4 to 6 in the sigmoid colon, and 2 at 2 to 3 in the rectum. The cecal lesions were lymphoid follicles. The transverse colon lesion was a tubular adenoma. In the sigmoid was another tubular adenoma and a sessile serrated polyp. And the rectum had a tubular adenoma and a hyperplastic polyp. So the summation over 2 colonoscopies is that she had 9 tubular adenomas. She had 2 additional tubular adenomas with high-grade dysplasia, and she had 1 SSP above the rectum. Next slide, please. So next steps for her, we're short on time, so maybe we'll just move to the next slide. In the United States, the National Comprehensive Cancer Network said, consider genetic testing for individuals with 10 to 19 cumulative lifetime adenomas, or if they have other extraintestinal manifestations of FAP, desmoid tumors, hepatoblastomas, the specific papillary thyroid cancer that's seen in the polyposis syndromes, usually unilateral chirpy, or individuals with serrated polyposis and the number of adenomas that meet the criteria, and that they recommend testing in people that have had 20 or more cumulative lifetime adenomas or bilateral multifocal chirpy. So on the right side of the slide, if there is a pathogenic variant known in the family, you test the individual for that variant, unless there's other cancers on the other side of the family that haven't been thought about, and you can consider multi-gene panel testing. For an individual like this that has no known family pathogenic variant, no one's been tested, Steve, if you just click again, maybe a multi-gene panel test is the way to go. So that was our next step, is to send her to the genetic counselors. Next slide, please. Okay, so if you're going to tell the patient to see someone and have a test done, what do you tell the patient the yield of multi-gene panel testing would be in her case? Steve, if you could go next. And this may be covered in, this is going to be covered in Dr. Macarone's talk, but basically this is the multi-gene panel test that we use, and you can see that it includes breast cancer genes, colon cancer genes, moderate risk genes, low penetrance genes, but it has a whole variety, including the Adenomatous polyposis genes. So I would love to see a show of hands, but I can't. So I was betting my money and my house and my twins that she would have something. And in fact, Steve, if you could get to the next slide, her multi-gene panel tested was negative for a pathogenic variant. So it was very shocking to me, 48 years old, no real risk factors, and there was some cancer, funny stuff in the family. So Steve, next slide. I think that's where I'm going to end the case, and we'll turn over to Dr. Macarone to talk to us about what is this diagnosis, and does she have one, and what is the management? Thank you.
Thank you so much. Let me see if I can share my slides. For some reason, I can't pull them up. Can you please, Steve, pull up my slides for my talk?
Yes, hang on 1 second.
Thank you so much. If I should close. Oh, thank you so much. So how should patients with multiple colorectal adenomatous polyps be managed? Next slide, please. So whenever we suspect a possible polyposis syndrome, it is essential to obtain a detailed family history. Like Dr. Berg said, we're talking a 3-generation pedigree. You want to know all cancers that happened, the age at time of diagnosis, but also know that family history may have some, might be multiple factors that could limit the benefit of family history, such as a small family, or in case of adoption, non-paternity, or there's something called de novo pathogenic variant, where the actual alteration in a gene happened now in the family in the patient that you are seeing. In addition to family history, you want to get the medical surgical history. You want to calculate their like we just did in that case, their cumulative polyp count. Are we talking more than 10 adenomas? And this is when you start suspecting an adenomatous polyposis syndrome. Is it more than 2 hamartomas? And then you start thinking about a hamartomatous polyposis syndrome. Or did we remove large serrated lesions proximal to the rectum that meet certain criteria? And this is when we define serrated polyposis syndrome. In addition to all of that, you want to do a good physical exam. There's a lot of clues that you can pick up on exams, such as extra, looking for osteomas, extra bones on the mandible, on the scalp. We always ask them about teeth anomalies, whether they have extra teeth or teeth that never erupted. And the chirpy that Dr. Burke mentioned, those are the bear tracks on the retina. So often we get refers from ophthalmologists for seeing these changes on exam. Next slide. And when we have a patient with multiple colorectal polyps, often you can put them in one of those 3 categories. Either they harbor an underlying germline polyposis pathogenic germline polyposis syndrome, so which means on the genetic test you picked up an alteration in a gene and a polyposis gene, and that's most often represented by FAP and MAP, but there's also some other rare, still clinically relevant polyposis syndrome that we check for and look for because they are actionable. If they don't harbor a germline mutation in a polyposis gene, the second category would be a germline mutation and a mismatch repair protein, and that's mostly represented by Lynch syndrome. Traditionally, we used to think of Lynch syndrome as a non-polyposis syndrome. Now we know that there's quite a bit of overlap, and particularly with oligopolyposis. And if the genetic test is negative, this is when we box them into this not genetically defined and most often represented by colonic polyposis of unknown etiology or therapy-associated polyposis, such as the case prior, or if they meet criteria for serrated polyposis syndrome. Next slide. So a choice of genetic testing, it is now standard to order a multi-gene panel test whenever you have a patient presenting with multiple colorectal polyps, unless there is a family, unless there is a pathogenic variant that is known in a family that you could single site and test. You're often obtaining multiple, you're testing for multiple gene, and all the commercially available tests are not the same. They do not have the same genes, and that's why experts have actually met, and in an elegant position paper, they defined the minimal set of genes that you should be testing your patients for, and that includes the Lynch syndrome gene and additional genes that are associated with increased risk of cancer. I have them listed on the slide, but I'll move over. Go ahead, next slide. And whenever you run your genetic test, you end up either with a pathogenic or likely pathogenic variant, and that means it's a variant that is disease causing, and the patients will be should be followed and managed according to surveillance recommendations, and at-risk relatives should undergo testing as well. This is what we often refer to as cascade testing. Or your results can be negative, and this is when we know there's no underlying genetic condition, but you still carry the phenotype, so patients should be surveyed based on their personal and family history. Most often now that we're testing for multiple gene, we end up with something with a variant of unknown uncertain significance, or VUS. Those are alterations in the gene that we're not certain they are disease causing because we don't have enough information on them. And patients should be, other than explaining to patients the finding, they should be treated based on their personal and family history, and at-risk individuals do not need to be tested. Now, every couple years, these VUS are reclassified. Most often they are downgraded, but sometimes they can be upgraded to a pathogenic variant, and in that case, surveillance would be recommended, and testing of at-risk individual is needed. Next slide. So what defines CPUE, or colonic polyposis of unknown etiology, like the case we just saw, is more then 10 cumulative adenoma, a negative pathogenic variant on a polyposis gene test, and a lack of prior exposure to therapy, mostly abdominal radiation or chemotherapy in the setting of early childhood cancer. Next slide. CPUE patients, how common is CPUE? It's fairly common. And Dr. Burke, one of her questions was what's the chance that we're going to pick up a mutation or a pathogenic variant on a genetic test? It depends on the polyp burden. This is a cross-sectional study that looked at over 3,700 patients who presented with 10 plus colorectal polyp. The data comes from a commercial lab, Ambry. Of those patients, about 13% end up with a positive mutation in any gene. The chances of picking it up went up to 50% in patients who had more than 100 polyps, but for those with 10 to 19 polyps, such as our patient, the chance of you picking up a mutation is going to be around 7%. Next slide. So in addition to colorectal polyps, increased risk of colon cancer, CPUE patients are at increased risk of upper GI neoplasia and thyroid nodules. And I'm putting here our data from the Cleveland Clinic, which we presented at DDW this year. And we reviewed our cohort, which is one of the largest cohort of CPUE patients in the country. We found that gastric and duodenal adenomas did occur anywhere from 3 to 36%. And thyroid nodules, particularly worrisome thyroid nodules that required FNA, happened in about 20%. We did not have any case of upper GI cancer or thyroid cancer in our cohort. Next slide. And this is showing you the distribution that to make the point that upper GI neoplasia happens regardless of the colorectal polyp count. We did see ampullary adenomas even in patients with 10 to 19 polyps. Next slide. For the next slide. For the thyroid findings, it was although thyroid nodules were common across all CPUE patients, thyroid nodules that are worrisome and that required FNA only happen in those with 20 plus adenoma. And this technically changed our way of managing our patients, CPUE patients. So we tend to order thyroid ultrasound on anyone with 20 plus adenoma looking for these thyroid nodules. And this led, next slide, the NCCN to update their recommendation it has been known that patients with 100 and more adenoma should be managed as FAP with colonoscopies and upper endoscopies and thyroid ultrasound. But it was quite of a debate whether the oligopolyposis patients of unknown etiology should undergo upper GI surveillance or thyroid surveillance, and it's now clear based on the recommendations from the NCCN that an upper endoscopy is recommended by age 20 to 25 in these oligopolyposis patients. There's still no mention of thyroid. I think we still need more data on that to make a statement. Next slide. So the bottom line is lots of polyps on the colonoscopy should raise concern for hereditary colorectal cancer syndrome, but that most patients with less than 100 adenoma have CPUE. Consider genetic testing in patients with 10 plus colon polyps, and multi-gene panel test is the current standard testing method for patients who have no family pathogenic variant that is known. I think this concludes my talk. We're pretty much almost on time, maybe a few minutes behind. If any of the panels would like to close with any take-home message, please feel free.
We're having some technical difficulties, but okay. I just wanted to thank everyone that's logged on to the event. We are a resource for you. As Dr. Macaron stated, she actually is running a Center for Gastrointestinal Neoplasia, and we have a monthly conference where we present protocols and difficult cases. As Dr. Liska mentioned, we have the Early-onset Colorectal Cancer Center, as well as the Weiss Center for Hereditary Colorectal Cancer, and we've expanded that to include CDH1, LIFRA, MENI, PTEN, a lot of polyposis and other hereditary gastrointestinal cancer syndromes. So if we could be of any help to you or your patients, we would like to hear from you.
And I appreciate all of the panelists. You know, we couldn't take care of patients and make differences in clinical care unless we had all the expertise that we have around the table. So our collaborative approach to management is really a help for our patients, as well as for, you know, all of the colleagues that are trying to do research and understand these diseases. So thank you, everybody.
Thank you very much. Thank you.